Thank you, Nick, and thank you for organising today. It's been a stimulating meeting, fantastic, and I've enjoyed this morning's sessions. Okay, so falls and overlap with syncope was what I was charged with, and I'll take you through some of that. I'm Roseanne Kenny from Trinity College in Dublin, and I've had a long-standing interest in syncope and falls and their overlap, and also how one should develop service delivery for all of these patients. And I hope today that we'll cover why should syncope and falls overlap, what's the evidence base behind that, and then what are some of the care pathways that we can employ in clinical practice to identify these patients and hopefully lead to some degree to admission avoidance. And I'll show you data with respect to that. So, first of all, why should syncope and falls overlap? And let's take a step back to the brain, because everything centers around the brain in this context, not the heart. Every single neuron in the brain has its own capillary. And if you were to stretch out the capillary network of the brain, it would be 600 kilometers in length. So the brain is a hugely vascular organ. The networks involved in gait and in balance are very complex, and they engage most of brain. Frontal lobe for executive function, occipital lobe for your visual senses, hearing, temporal lobe, etc. So the networking involved in gait and balance is huge, and the brain is a very vascular organ. If you're going to impact on that vascularity and have repeated episodes of hypotension, be they not enough to cause loss of consciousness, they could still contribute to falls. So that's one way why there's an overlap in the underlying mechanisms for syncope and for falls. And the second, of course, is amnesia for loss of consciousness. And this is just a graphic to illustrate the relationship between neural networks and gait and balance. So one of the reasons is amnesia for loss of consciousness. And we know now from a large series of studies that probably 20 to 30%, particularly older persons, but not exclusively, who experience transient loss of consciousness have amnesia for losing consciousness. Now, we've known this in the epilepsy world for a long period of time, and in the last 15 years, probably in the syncope literature. And then, as I've illustrated, hypotension itself can lead to cerebral hypoperfusion, and an acute cerebral hypoperfusion, enough to cause a fall at the time, but not perhaps loss of consciousness, or repeated hypotensive episodes can damage those neural pathways we talked about and influence gait and balance in a more chronic way, leading to instability and falls. So that's why these two symptoms, falls and syncope, overlap. Let's look at some of the evidence behind all of that. Well, there is evidence in induced loss of consciousness. Any of you who run a lab trying to make people black out will have seen this, that you induce loss of consciousness, even in some patients during an active stand if there's significant orthostatic hypotension, or during tilt-induced loss of consciousness or carotid sinus massage. Patients will lose consciousness. You'll have witnessed the consequent hypotension and, in some cases, bradyarrhythmia. They'll recover and they won't be aware that they've lost consciousness, but the staff have obviously seen this. So we see this with hypotension, with bradyarrhythmias, etc. And one of the studies which has shown this is one that we happened to do on a series of, I think, 159 patients who had tilt-induced loss of consciousness. And we showed that in those under 60 years, almost a quarter had immediate amnesia for loss of consciousness, although they had witnessed loss of consciousness. And for those older, over 60, that was much higher. 50% had immediate loss of consciousness. And then 20 minutes to a half an hour later, it was slightly better for those under the age of 60. And again, some improvement in those who had recall for the over 60s, but not huge. So amnesia for loss of consciousness demonstrated in an acute laboratory setting. And then in a systematic review, we asked the question, with respect to cardiovascular conditions and falls in people over the age of 50. What is the evidence from the literature? And found that there were positive associations between falls and cardiovascular disorders for low blood pressure conditions in 4 out of 5 papers, heart failure 4 out of 5, cardiac arrhythmias 4 out of 6. There was a higher prevalence of falls in carotid sinus hypersensitivity and vasovagal syncope and postprandial hypotension. And then inconsistent associations at this time in the literature, I think it was 2016, for coronary artery disease, for orthostatic hypotension, solely orthostatic hypotension as an isolated cardiovascular condition, no other comorbidity, cardiovascular comorbidity, and hypertension. So there is something in the literature which supports the overlap. There is further work showing that atrial fibrillation, one of the commonest arrhythmias that we see, is associated with gait and balance instability in a large community study of almost 9,000 people. And that atrial fibrillation is also associated with syncope and falls in that same general representative population study cohort. And the recent Cochrane review summarised interventions for preventing falls in older people living in the community as follows. Evidence from 3 studies indicate that pacing in people with carotid sinus hypersensitivity, and of course bradyarrhythmic version of that, and a history of syncope and or falls, subsequent falls rates are reduced by cardiac pacing, suggesting that the intervention actually was reduced falls rates. And the sort of case that I'm illustrating with respect to this is the following. This is a retired porter seen by us in 2015, 77-year-old, lived alone. He was admitted in February. He'd been walking midday, had had a fall, unexplained. What do I mean by unexplained? He didn't recall tripping or slipping. He was cognitively normal, so should have had that recall if there had been something, and just went down. He was clear he did not lose consciousness. He had a laceration, and you can see the remnants of that here. And no witness account occurred when he was out of, not in contact with others. So he was admitted to a general hospital ward, medical ward, the sutures sorted, etc., and normal electrocardiogram, history appeared normal, discharged. Readmitted in March. And at this time, he had been going to the toilet at night. He had a further fall, denied again loss of consciousness when he was interviewed by the team, and had this bruising, so this was the index event. He was on no drugs, no previous cardiac history, and no prior head injury. So you've got an unwitnessed event, not a lot historically to go by, two events, and certainly both of them injurious. So we saw him 3 days after his admission as an inpatient in the falls unit, falls and syncope unit, and his examination was normal, but we felt because these were 2 unexplained events, he was at risk of further events. And because they were unexplained and injurious, we implanted a loop recorder. And after some time, he had a further event, and as you can see, a significant bradycardia associated with that fall event. He had a pacemaker in 2015 and has had no further events. Now, how common is this issue if we fast track to the emergency department? And this is data from our ED in the teaching hospital associated with Trinity College, St. James's Hospital. And as far as I recall, this is for a 6-month period because we estimate that 4,500 people of all ages are seen with falls each year. This is about 2,000. So what you can see is this is age here. So falls are a really common reason for presenting, but also for all ages. Now, the hospital is based in one of the lowest socioeconomic grouping areas in Dublin, in Ireland, actually, and much of this would be related to extraneous intoxicating substances. But over the age of 60, what you will notice is that, and Bob Sheldon alluded to this earlier on, is admissions for falls becomes much more common. And particularly over 75, over 50% of people who attend our ED with a fall are admitted. Now, EDs are really busy places, and it's very difficult for ED staff to spend a lot of time, in my opinion, taking histories and risk stratifying in an in-depth way when there's so much pull on their time. And I know our emergency department is no different to the majority in the UK, which can be crazy sometimes. We actually applied, if you fast back to that 77-year-old porter, the ILR to consecutive admissions through the emergency room who had come with 2 or more unexplained falls. So the index was an unexplained fall, and they had had a previous unexplained fall in the last 12 months, no syncope. And in 70 consecutive patients, we followed them for a 9-month period. Attendances over the age of 50 were selected, and they all had a detailed falls risk assessment, including a cardiovascular falls risk assessment before we put the ILR in, which meant external loop recording for a week, obviously a surface electrocardiogram, obviously a cardiac examination, and carotid sinus massage. And 70 had of those who had come, mean age 69, 9 months follow-up, 71% had an arrhythmia detected during the 9-month follow-up period, which hadn't been apparent previously. Half of the cohort had a further fall event, and 28% of the cohort had a fall and arrhythmia at the same time. So that's a third, suggesting a causal association between the arrhythmia and the fall. And the majority of arrhythmias were either a bradycardia or a systole, or supraventricular tachycardia and atrial fibrillation. And some of the patients were on beta blockers, and so in some cases medications were modified, and in other cases patients had a cardiac pacemaker. So that's a pretty high prevalence in this particular patient group, and it's an observational study of previously unknown arrhythmias and a third arrhythmia at the time of the fall, suggesting causality. Furthermore, falls were 5 times more likely to recur in patients who had an arrhythmia detected, independent of its association with a fall event. So that's suggesting something in the background pathophysiology shared between these fall events and arrhythmias, which might come back to what we opened the presentation with, and that's this impact of repeated hypotensive events on neural pathways for gait and balance stability. So how are we going to manage this? How can we readdress these issues in the health service to the benefit of patients and early detection of these modifiable arrhythmias? So Richard mentioned this morning that we started the European Society of Cardiology guidelines for syncope in 2001. And I have been bleating on since that time about this overlap between falls and syncope. And I'm delighted to say that 17 years later, the concept of unexplained falls has been introduced into the guidelines and recommendations for that category, which I'll come on to in a moment. Furthermore, we have also been proposing for a period of time, and we've actually written guidelines with the EHRA and European Society of Cardiology on the recommendations, rather, for requirements for a syncope management unit and the rationale for a unit, etc. And that has also been introduced into these recent ESC guidelines. And there are some really nice criteria in these new guidelines with respect to how to manage both of these issues in the emergency department. I don't have time to go into these in detail, but I highly recommend them, and they're on the web. And with respect to falls, this is the algorithm that we've applied in the ESC guidelines. Falls in adults, if it's non-accidental, explained fall, unexplained fall, non-accidental, so not a slip or a trip, an unexplained fall, syncope likely, like in our Porter gentleman, then the evaluation should be the same as for cardiovascular syncope. If it's explained, impaired gait, balance, cognitive status, environmental hazards, you can still probably have an explained fall with these criteria, which may have elements of hypotension, which are underscoring the fall's susceptibility. But anyway, we came this far, which is a major step. And that fits nicely, and nobody's talked about risk stratification this morning, so I'm not, and it's a lecture of itself, but this is the syncope risk stratification recommended for ED. Low risk, neither high risk, or any high risk features. And the care pathways applied to the risk stratification are different. And they're also very similar for falls. And basically, the risk stratification depends on history. Was the person lying down or sitting down when it happened? Were there palpitations or chest pain, etc.? So red flags for history. Physical examination, any evidence of structural heart disease, and if so, what was that evidence? Electrocardiogram, and I'll come on to some of that in a moment, and past history, family history. So they're the sort of red flags that make you think there's something more going on here than a reflex syncope, which is situational or orthostatic, and if it's a single event, person could be discharged from ED. If you're not happy as an ED doctor doing that and putting a full stop there, if they're recurrent, then referred to a syncope management unit, and that's where this specialist unit comes in. And if you're not quite sure whether it's high risk or low risk, and that's not uncommon, shouldn't be discharged from ED. They can be observed for a period of time in the emergency room, and this is based on the Mayo Clinic's SEEDS data study, or referred directly to a syncope unit, rapid access unit, and I'll talk to you about that in a moment, or admitted to hospital. And at the moment, these are kind of coming in here in most practices, and we've looked at prevalence across Europe, and that seems to be the case. So this may be a mechanism for admission avoidance. And if you can do that to a sufficient degree, you have a really good business case for developing this in detail. Now, this was given to me by one of my colleagues in ED. We have a great relationship with our ED, actually, and I work very closely with the ED department. And at now, what we've done is we have a consultant, a registrar, and a nurse who are trained in syncope and in medicine for the elderly, and they've done some training in neurology, all three have. And they're based in ED now. This is a trial for a 1-year period to see if we identify people with falls and syncope of all of those ages, 16 and above, fast track them through to the syncope and falls unit, assess them on that day. How many admissions can we avoid? And it's looking like 2 a day in a emergency room which sees 50,000 adults a year. So that is enough of a business case to fund the unit. And we want to avoid admission, particularly as people get older. They do really badly if they're admitted to hospital. So Wobbler is a quick a tool to use for ECG, electrocardiographic indicators for high risk. So just remember it, it's cute. Don't mix it up with the bird, the warbler. So, through SAPIA, which is the Science and Advisory Group for Policy, European Academies, it's a compilation of the European Academies, and myself and Daya Ku from UCL and Jean-Pierre Michel from Switzerland have chaired a guideline report on behalf of SAPIA and for public health interventions, transforming aging in Europe. And one of the things that we've managed to include is a compilation of those 2 previous algorithms you've seen, combining falls, accidental, non-accidental, unexplained, syncope pathway, low risk, intermediate risk, high risk, recurrent falls, low risk, single event, no further follow-up, but not falls and syncope unit, intermediate falls and syncope unit, high risk, hospital admission, etc. So combining those, these recommendations, we hope, will be embraced by the European Commission, which commissioned this report, and one of the remits was admission avoidance, and how can Europe, which is facing this huge issue, virtually all European cultures are facing this issue of a high density of admissions. So this is the paper which scopes out what the rationale and requirement of a syncope unit is, and I would recommend it for your reading, Europace 2015. And based on that and the new guidelines, and based on the fact that, particularly in people over 65, 25% of all attendances, this is an average for Europe, 2 EDs in Europe is because of a fall. Not syncope now, it's fall. And 25 of all attendances are people over 65. And 20% of those are because of a fall. And it's 1 to 4% for syncope, pure syncope. But you hear what I'm saying? We're trying to package these as the same, because the process for assessing is very similar. So I described the model that we've applied, a same-day assessment in a syncope management unit. And the other thing that affords, and this is something that was touched on this morning, and it's hugely important, that multimorbidity in people over 60 is the rule, not the exception. In the population study that we're running, 12.3% of people over the age of 50 are on no drugs and have no known comorbidity or morbidity, okay? 12.3% over 50, 2.6% over 70. And the Academy of Medical Sciences here has done a lovely paper on this recently, emphasizing the importance of multimorbidity. And this just gives you some of our work showing that the bigger the bubble, the more common it is in a community sample of people over 50. Mean age 64. Arthritis, big, but look at the strong association, more than you would expect with hypertension, high cholesterol, cardiac arrhythmia, angina, diabetes, depression, obesity, incontinence, etc., cataracts. So these are the common comorbidities, and they're often associated, which is really interesting from a pathophysiological and mechanistic perception. So your syncope unit, I would recommend, should look to the 4 Fs. Fits, faints, falls, and I spent a long time in Newcastle and we call them funny boots. Nobody knows what I'm talking about, so funny do's. And then my last word of caution is, possible caution, is the recent SPRINT study. So the SPRINT trial is a great study of people over the age of 50, aggressive treatment of hypertension in the intervention limb to a systolic of 120, measured orthostatic blood pressure using automated dynamometer, sitting and standing every 2 months during the study, 3.4-year follow-up, and showed a significant reduction in all-cause mortality. We took the criteria for SPRINT and applied them to a population study. In other words, how common or how much more would we have to treat blood pressure at a population level to meet the SPRINT criteria? And over 75, it was a bit counterintuitive that you could make a homogeneous recommendation for aggressive lowering of blood pressure. Now, we're, of course, coming from a very biased sector, which is 40% of what we do is stop or reduce drugs. So in that context, we were actually able, just take my word for it, to apply the methodology used in SPRINT to the Tilda population sample over 75, because our follow-up period between waves of this longitudinal study where the same people were followed repeatedly was the same as the 3.4 years of SPRINT. Bottom line, we looked at injurious falls and syncope over that period of time at either wave in people over the age of 75. So SPRINT criteria applied to a quarter of people over 75. And at either wave, this was the prevalence of injurious falls for us. It was almost 30%. And of syncope, it was almost 12%, over 12% actually. In SPRINT, the The reported prevalence for that same age group with the same criteria was 5% and 2.4%. And actually, orthostatic hypotension was less common in the intervention group in sprints. I'm not sure what's going on. The methodologies were very different because we used the phenometer that you saw Boone showed us earlier on. But just to say, also in that sample, this is the sample who the sprint criteria are being recommended to be more aggressively treated. 48% reported a fear of falling. 27% had falling which was limiting their activities. And I'm thinking, you know, as any of you who are dealing with these patients would be maybe slightly hesitant about aggressively reducing blood pressure. A third had orthostatic hypotension at 40 seconds, which we know is a cutoff for significant OH. And 18% had orthostatic hypotension using the same methodologies as with sprint. So all I'm saying is that for this age group over 75, we do not think that these data, I'm not going to go into that, can be generalized. And I would say we should introduce some caution that the sprint sample is generalizable to those over 75 until we've got a lot more information on intervention in that particular cohort and a representative sample of that cohort. So I leave you with the thought that we should maybe be addressing falls and syncope as the same symptom, and that applies to all age groups, and that if you're going to establish a facility to address these big issues, which I think we should be thinking about seriously because there's good evidence emerging that it will be a cost-effective care pathway and efficient in many other ways in terms of applying the guidelines, it should be for all ages and for these two symptoms at the very least. Thank you.